Good morning, everyone. I'd like to thank you for joining us this morning. We have a full agenda today, so without any further ado, I am going to turn this over to Jess.
Thanks, Becca. Good morning, everyone. Thanks for joining us on this rainy, dreary Friday morning. At least it's rainy and kind of dreary in Jefferson City, but it is a Friday. If you are new to us, I'm Jess Back, the Division Director for DD, and don't worry, I'm new too, and it's a great morning to have some coffee, but I also thought it was a great morning to, I can put my coffee cup in there, because if you don't like cat prosthetic, it's probably time, I've been here 2 months now, to let you know that I am a crazy cat lady. I introduced, in my introduction email to our staff team members, I gave them just a little bit of information about my family, including the fact that my girls had just gotten a new litter of kittens for the summer to play with, which was exciting for them. And that was true, but what I didn't mention was that, because I didn't want to sound crazy, was that we actually had 3 litters of kittens that we got right at the beginning of summer. So we had about 16 kittens for them to play with, almost all of which have found homes now. But if you're in the area, we still have 3 more that need a good home. Without further ado, we do have a full agenda today, so I'm going to go ahead and get started, but just kind of an overview of what we're going to be talking about. A large amount of the time today is going to be spent dedicated to talking about COVID and the surge that we have right now and new information that's available. Very excited and grateful that Dr. Stanislaus could join us today to provide great updated information, and also wanted to get everyone's feedback on the frequency of these meetings relative to the situation right now. We had made the decision to move to a monthly call from a biweekly call last month. And now that the situation has changed a bit, love to hear your feedback through the chat. If you can just let us know if you think we should increase the frequency due to the situation right now or for other reasons. You just like to hear updates more often, we would greatly appreciate your feedback on that. The other things we're going to talk about, we have updates on budgets, a few general updates on information that's come out from the division that we just want to make sure is clear. Station MD has joined us to share some great information. And we also have Leslie from our federal programs unit on, who's going to share some information, updated information about our waivers and the processes that we're in for approval with CMS. And the first thing I wanted to talk about was the fact that due to the situation with COVID right now and the surge that we're in, we did send out a memo on June 29, letting everyone know that we were returning to remote monitoring status for case management. And that decision was made and included one major difference from the previous time period of remote monitoring when we had high levels of COVID transmission. And that is that there are some individuals who have not been seen in person since the return to in-person monitoring in April. So there is information in that memo and guidance which explains that we do still want and expect that there is an in-person visit unless there's extenuating circumstances for those individuals who've not been seen in person since the return in April. The effort really is to reduce the footprint there. As we are going through this time right now, we want to do everything we can to mitigate risk. And one of the ways that we can do that is we know that remote monitoring was successful, and you guys did a great job in that and learned how to, working through all the technicalities. So really going back to that during this time period is the right thing to do given the current situation. You may have noticed on July 14th, 2 days ago, we did send out some updated information in that guidance, and that was to provide additional documentation examples with some questions in response to some questions we had gotten from TCM agencies and support coordinators. So if you want to check that out, there's some good information in there, good examples for documentation. The other question I wanted to talk through regarding that is we do have some agencies that have reached out to us and asked if it's okay to continue the in-person monitoring. And yes, that is okay. And but it's a decision that you should be making regarding the situation specific. So really looking at what is the current situation in your community, what's the current situation with that specific provider, with that client, and taking that all into account, having a conversation with the provider. If the provider is wanting to do remote monitoring, we ask that you honor that. We did have a couple questions, I think maybe just one question that came in regarding a provider who was refusing to do remote monitoring. So if that's the case, we really just ask that you reach out to the regional staff, the TCM TAC, to talk through that specific situation and come to a resolution that way. The other kind of one of the questions that came in as we are back in the situation that we're in right now is regarding, is there specific guidance from the division regarding how providers need to develop, how they approach the care and the masking and community integration during this time period, and a lot of questions about will there be specific guidance from the division. So really just wanted to reiterate that information that has been provided in the past, that the expectation from the division is that providers and partners follow the CDC guidance, and that information is continually being updated based on new information that the CDC and experts are able to obtain. And it really is back to that situational specific circumstances again. So it could be a participant who is fully vaccinated and they have really felt the effects of social isolation, and maybe that community is not in a high transmission. So for that individual, it may be a better choice to have more community integration, whereas you may have another client who has refused vaccination for one reason or another, and they're high risk, so you wouldn't necessarily want to follow the same guidelines in that situation. And so really what we ask of providers is that you have policies in place for your staff regarding the CDC guidance and following that, and are just following up with staff to make sure that they are following your policies based on that CDC guidance and understand it and are able to kind of collaboratively work with you regarding the situational specific things that come up and in many different circumstances. So wanted to just make sure I touched on that. One of the things that we are going to be sending out through an email blast, and so I just want to call your attention to, is a really great document that came out from the Administration for Community Living this past week, and it is a book developed by them called 30 Years of Community Living for Individuals with Intellectual and/or Developmental Disabilities. And I really want to thank the people at ACL for personally developing this right when I came into this world as new to this world, and this was really helpful of them to put this together for me to understand the history and where we're at now and where Missouri falls with regard to other states. So it's a great document. I encourage everyone to take a look at it. It's very informative. So we'll be sending that out through the email blast. I mentioned earlier, Station MD is on with us today. And one of the things that we are going to be sending out as well is information for you to use as you do staff orientation and do training. It's really a tool for providers to use if they need it to help inform staff about Station MD and how to use it so that that burden's not on you. And I'll share my screen and just give you kind of a preview of what that looks like. To the right document here. Micah, can you see my screen?
Yes.
Okay, great.
We can see it.
I'll make it just a little bit larger, but here's the one-pager that is going to be coming out, and it's really something that you can put your agency letterhead or logo on and hand to staff so that when they're taking in all of the information, they have this handy to go back to understand that Station MD is available for them to use and for clients and families to use as a resource, how to use it, when to use it, and who to call if they have questions about it. So we hope that that's helpful, and just wanted to bring that to your attention that will be coming out. Another thing is just a reminder of, for some, and if you aren't aware of it, there's some great information that we put out regularly on our dashboard on the department's website, and Heike can share the exact link in the chat for you. But this information is really helpful in providing a lot of different types of updates. So just information in general about, and it's updated very frequently. So it's up-to-date information about the department and our services, and so you can see the different COVID cases that are going on. You can see the community cases, where they're at. You can look at investigations, licensure and certification activities. A lot of people find this helpful. Here's the waiver counts, the current waiver wait list, and expenditures by waiver, updates on technology and Station MD use. So just wanted to remind everybody that that is out there, and it's something that you can access anytime and get up-to-date information. Here's some information about due process and our current client risk category that the tiered support team is working on. So I will stop sharing my screen right now and get ready to turn it over to Angie, who's going to go through some budget updates. But I did want to say that I've had the chance to go out and visit with 2 different providers now, and then had the opportunity last week to visit with the Raleigh Regional Office team, and it's honestly one of the best days that I've had in such a long time. It was such a really great conversation about the work that is being done locally, and the staff there had great things to say about their partnerships with local providers and the TCM agencies, and kind of all of the community collaborations that are going on, the great things they're doing. and I just wanted to thank them for their time and for their dedication to what we do. And I'm looking forward to getting out to all of the regional offices and facilities. May have to slow down on travel a little bit just because of the current COVID situation, but I look forward to getting out around the state and different providers. So thanks again, and Angie, I will turn it over to you.
Okay, thank you, everyone. Thank you, Jess. We have some budget updates to give you. There's quite a few here that get a little wordy, so bear with me. Rate standardization funding was approved for individuals receiving residential services, so that's our group home and our individualized supported living services, to align with our state fiscal year 2020 lower bound market rate from our Mercer rate study that was done back in June of 2018. Those rate increases will be implemented on an individual basis and upon approval of our HCBS Enhanced FMAP spending plan, which I will talk about that here in just a little bit. When General Assembly passed it, in lieu of using the state general revenue, we are proposing to access the Enhanced FMAP funding. And that is a total of $166.3 million. And then we have some other changes here, rate increases to personal assistance services. This first rate increase for the personal assistance service is to increase it to be consistent with the state plan market rate base adjustment for personal assistance. So this is just to get us to where we're matching Department of Health and Senior Services personal assistant rates. That is in the tune of $4 million. And if there are rates that are above the state plan service, we will not be decreasing those rates. Only those that are below will be brought up. And then for personal assistance, in addition to that, bringing them up to the market rate for DHSS, there is an additional 5.29% increase to the current maximum rate. And that is also utilizing the HCBS Enhanced FMAP funding. And so that's another $4.9 million, but that will not be able to be implemented until CMS approves our spend plan. And then another rate increase would be a 5% rate increase to our day hub services, which includes day habilitation, individual skill development, community integration, and our employment services. And that was at a total of $6 million in funding, again, including state and federal. And then an increase to our reimbursement rates to applied behavior analysis services that are specifically provided by the registered behavior technician and licensed assistant behavior analyst, and that was about $210,000. That was for services specifically. So we are in the process of getting those rates, those new rates on provider contract, implementing them in Seymour. This week, we are going through the testing process to make sure that the 5% increases have been included into Seymour and the 4 applied behavior analysis rates. So we're hoping to have that testing complete this week. And then our provider relations team and our procurement office is working diligently to get the personal assistance services, any of the OHCDS and the purchase of service codes updated on the contracts and into our system. Those all have to be done manually, and we anticipate having those complete by the end of this month. And then there has been one more change, not specific to rates, but we are transitioning our group home, the 5 scales, moving from the CIS to the MAS scores. That is being implemented this month as well. And so they are in the process of changing those authorizations in the system, and they plan to have those completed by the end of this month. That brings us to our HCBS Enhanced FMAP spend plan that we're talking about. This is an addition to the American Recovery Plan that CMS has put out that was passed. CMS is requiring all states that want to access this 10% additional enhanced FMAP to submit to them a spend plan explaining kind of what we intend to use that funding for. And so Missouri submitted their plan to CMS on this last Monday, July 12th, and CMS has 30 days to respond to that plan. And our spend plan, it was a collaboration between Department of Mental Health, Department of Health and Senior Services, as well as Department of Social Services. We did include a request for an expedited approval of the components that were included in the fiscal year 2022 funding portion passed by the General Assembly and signed by the governor. Additional components that were in that spend plan include an expanded use of technology and telehealth, quality improvement activities, data integration efforts, workforce recruitment and support, enhanced care coordination. MoHealthNet has that spend plan posted. They just posted it very late yesterday for public comments. We are in the process of getting an email blast sent out to share that link, and really looking forward to any feedback that we get from stakeholders. And then in addition to that public comment period with the posting, we are collaborating with Department of Social Services and Department of Health and Senior Services for further stakeholder engagement, and just trying to kind of reach out to all the different stakeholders in various areas to get a more robust feedback from everyone. So we plan to have our feedback gathering wrapped up by the end of August. Okay, we've had a few questions about Medicaid asset limit versus Social Security asset limit. This is the first time that those two asset limits have been different. So historically, you know, we've set those to follow the Social Security asset limit, which has been like $2,000. This year, that has been increased for Medicaid participants where their eligibility is based on disability and they're not receiving SSI. So we're in the process of figuring out that discrepancy, developing a report that will assist the business offices and the support coordinators and providers to distinguish those individuals that have an asset limit of $2,000 versus those that have the asset limit of $5,000. As we work through this, we will update the Division Directive 5.101 to reflect the new process. Hopefully we'll have that done within the next few weeks. And then the final question that I have that's come up quite often has been the stimulus funding. So just wanted to remind everyone that money received from the COVID-19 stimulus should not be considered as an available resource for 12 months from the date that it was received. But after that 12 months, it is considered as an available resource. And I know that the business offices are working closely with individuals and families about opportunities to use that fund, such as using ABLE accounts and things like that. So if you are hitting that 12-month point, make sure you're working with the business office and your support coordinators and your and families on how you want to use that funding. So I think that is all I have from my side. Jess, I don't know if you had anything you wanted to add about any of these or the spend plan.
Yeah, thanks, Angie. I did not have anything to add. Thank you for covering that. We're really looking forward to getting stakeholder feedback, but the spend plan was largely based on information and feedback that the division has received from stakeholders throughout the past year and recently as we talk about needs. There was one question that popped up, Angie, related to the rate increases being in Seymour. And it was, since we are doing a test in Seymour this week for DayHab employment ABA rate increases, when do you anticipate the updated rates will be reflected in Seymour?
I think they should be, after this week, after we finalize that testing, that should be able to be implemented almost immediately. But I will double check on that to make sure and let you know.
Okay, great. And then we'll send information out to providers based on that.
Yep.
And a couple of questions that popped up that I did want to address real quickly. The first one was regarding ability for state staff to work remotely given the current situation with COVID, and we could not agree more. We have been working very hard on plans to move forward with going to distributed work and returning to that, and that information has been submitted to the governor's office for their review. I also wanted to thank Emily Reinhardt on the DD team for the work that she did as part of her Leadership Academy team they did a presentation to the governor and several key leadership staff regarding distributed work teams, and that information was very well received. So really appreciate the work that she and that team did. So expect more communication on that very soon. We will let you know as soon as we hear anything, but we would like to move that direction, and we'll keep you updated. The other question was regarding verbal signature flexibility. We all know that, are aware of that state flexibility order of emergency expiring here shortly, and so we have requested that those flexibilities currently in place are extended, and expect to hear back from the governor's office legal counsel on that very soon, and we'll be sending out information to verify that those will be extended. So appreciate the great questions, and we will move on to Leslie. Thanks.
Thanks, Jess. The division continues the formal request for additional information, or REI, with the Centers for Medicare and Medicaid Services for the comprehensive and community support renewals and the Partnership for Hope and MOCID amendments to align with those renewals. As the renewals were set to expire June 30th of 2021, CMS granted the division temporary extensions for both waivers to continue operating through September 28th of 2021 to provide the state with additional time to respond to REIs and make all revisions to the waiver renewal applications necessary for CMS to approve. And CMS formally stopped the clock on the consolidated COVID-19 Appendix K waiver amendment to add the new health assessment and coordination service through REI. And the state responses were submitted to MoHealthNet yesterday for review before submission to CMS. And those were the two updates I had. Thanks, Jess.
Thanks, Leslie. Appreciate that information and keeping us updated. And now I am very pleased to turn it over to Dr. Stanislaus for updated information.
Thank you, Jess. Good morning, everyone. So, I really thought my job was done once we got through the last spring outbreak and then in winter. But I'm sorry to say that we are having another big outbreak this time, and we really are trying to put our heads together to really figure out what's the best way to move forward, because there's not much we know about this variant. Nevertheless, I'm going to share what we know for sure, and also I'm going to say what we do not know yet. And I have to tell you that we have more information that we do not know than what we know. So the current outbreak in Missouri, it started in the Springfield area, the southwest part of the state, and from there, it has been moving to the rest of the state. I talked to Dr. T, who's our state epidemiologist, yesterday, and he said that more than 80% of the viruses, of either both, we're checking the sewer as well. Missouri does a sewer testing of sequencing of the viruses, and they find it is Delta, and also they sequence them in a state lab, and they found that to be Delta as well. So currently, about 80% of what we are seeing in Missouri is the Delta variant. So if you go back in time, just to show the history, when we first got our the COVID, and especially in Missouri, it started in New York, and then it got away by spring of 2020. We had our outbreak in Missouri, and it spread fairly quickly in April and May of 2020, resulting in mortality and resulting in increased hospitalizations and mortality. Now, that variant was not a variant. That particular virus is what's called the original virus, or some people call it the Wuhan variant, which actually originated from China and then went around the world, including the United States. So most of the information that we have on COVID is based on the original variant. So that is kind of the baseline, what we have. Most of the information, if you go on any of the research, it's all based on the Wuhan, or the original strain. I'm going to call that the original variant. It's not even a strain. The original, not even a variant. That is the original SARS-CoV-2 virus. Okay. And then let's move fast forward. We got through that part, and then we had in winter, January, February of 2021, we had a variant that's called the Alpha variant. That is the one that we had from the United Kingdom, it originated from there, and that is the Alpha variant. And that had a little bit of change in the spike protein. The spike protein is a little thing on the head of the virus that attaches to the receptor cells in our body, mainly our respiratory tract. That those spikes, those spokes, those are the spike proteins. So the Alpha variant was something that made some changes in the protein structure of the spikes so that it can attach. It's more like Velcro, so it acts more like a Velcro to go attach to our receptors a little bit faster. So they said the information we had was that alpha was about 2 times more transmissible, meaning that it can attach faster, and then because it can attach faster, it can move faster through vulnerable individuals quicker. Now we have the Delta variant, which was originally detected around the end of last year. It really took off in India in February of 2021. And then it went to Israel, United Kingdom, and most of the world is currently going through the Delta variant pandemic, or the spike in COVID due to the Delta variant. And now, I mean, United Kingdom is also in the middle of it, but they are about 4 or 5 weeks ahead with the experience with this particular virus. And now, unfortunately, for Missouri, we are ground zero for Delta. It's mainly Arkansas, Southwest Missouri is where actually the first big outbreak of Delta has happened. Because of that, there's so much more we do not know, and we are kind of like trying to figure most of these things out. So what do we know for sure about the Delta variant, or Delta variant of the SARS-CoV-2, or the virus? Number one, we know that it has made enough changes in the spike protein, or that spooky protein, that its attachment to the receptors is more potent. So it can go in and then gets really, really attached to the receptors in our respiratory tract fairly quickly. The second thing what we know is once it enters, it also multiplies very, very rapidly. They say that the viral load is the number of virus that is found in a small point, how intense or how much virus we have in, let's say, in a droplet. That is the viral load. So the viral load is 1,000 times higher than the original Wuhan strain, or the original virus. It's 1,000 times higher. So that just tells you how much more virus is packed in, let's say, a droplet that comes out of our mouth or our nose when we breathe in. That's how much. If an infected person coughs or breathes, or they're speaking, they don't have to cough either than just speaking. Those little water droplets the salivary droplets that come out of our mouth, how much more, if they are infected, how much more it is densely packed. So that is the viral load. The other thing we know is also the ability for it to move from person to person. That's called transmission, how fast it can transmit. Compared to the original one that came in the spring of 2020, this is about 225% faster. So it goes into the body, it multiplies quickly, and then it gets out and then keeps moving faster. And this is the reason we are seeing this very quick, rapid increase of the Delta in Missouri currently. Very, very quick. I think within 2 to 3 weeks, pretty much it has replaced all the Alpha variants and other variants, and just taken over. So that's what is so different about this Delta variant. It's more, it multiplies quickly, it's more infective, and it's more transmissible. Okay, so that is the kind of a thing we're dealing with currently. So what do we do not know yet? What we do not know is vaccines and protection. So what we do know is all the lab studies we've heard so far from the vaccinated individuals and United Kingdom and Israel clearly indicates that it offers a level of protection for vaccinated individuals, specifically when related to serious illness and death. So what Israel has shown is about half of the individuals who were, about 45% of individuals who were vaccinated still had tested positive for SARS-CoV or the COVID. They tested positive on PCR as having the infection. But what they found is when they looked at the data, or when they compared the data of individuals in the hospital and who were dying, they found it was the unvaccinated individuals who were in the hospital and were dying. That does not necessarily mean that nobody who was vaccinated did not die. That is not true either. But when they looked at proportions, it was much higher for unvaccinated individuals who were in the hospital. And they used the word overwhelmingly higher for those who are vaccinated, who are unvaccinated was compared to vaccinated. Now, vaccinated individuals have been in the hospital. That we know of deaths that have happened in vaccinated individuals as well. Okay, so that part of it, we still have to, was there any particular predetermination or were there any other factors in those individuals who actually died after vaccination? We do not know. So those are the things we really, really do not know the data on. The other thing we know is more in a community, when there is more unvaccinated individuals, the peak is much higher for the Delta because it's able to move very, very quickly again with the unvaccinated individual. Whereas when communities where they have a lot more vaccinated individuals, then its movement is slower, much slower. It's not to say that it's not moving at all, but it is much slower, and there is a lot of data to support that right now. So saying that, what are the other things we know about the Delta? The other thing is what we know is because it multiplies so fast, if you remember for the original virus, typically people turn positive between day 4 and 6. So I would ask individuals to test them by day 5. If you have an exposure and you're going to do one test, I would say do it on between day 4 and 6, but I would choose day 5. Now, because it is multiplying so fast, that day has moved one day earlier. So now the best time to test, if you're doing one test on PCR after exposure, would be between day 3 and 5. So day 4 would be ideal, but the day 3 and 4 is important to know. Now, if you remember even with the old virus, the original virus, I'm not calling old, the original, it used to be that people were infected or able to transmit to other people even 24 hours before the onset of symptoms. So it'll be the same thing here too. They can still be infected for about 24 to 48 hours, even before the onset of symptoms, because initially the virus goes into the body, multiplies rapidly, and then the body reacts to it, and that's when we have the symptoms, because the body is trying to get rid of the virus by either runny nose or cough or whatever, the body's just trying. Those are the fever. All those are body's way of coping with the virus and finding ways to push it out. So that before we have the symptoms, a day to 2 earlier, you're already capable of infecting another individual. Now, what's the difference between those who are vaccinated versus unvaccinated in transmission? That is something we do not know. What we do know is, have individuals who have been vaccinated and have COVID been able to transmit to others? The answer is yes. There have been, but the unvaccinated, again, it's more like, vaccinated, lesser degree, unvaccinated, higher degree. That's what we're looking at currently. How much lower, how much higher? We still need data on that. All right. The other thing is we are specifically looking at outside transmission. We know that the original virus, we found that the outside transmission, especially if we maintain decent distance in outside transmission, outside in the community, like if you're in the open air, the transmission rate was very, 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 very low. Of course, if you stood very close and spoke to each other's mouth, doesn't matter what the virus is, it doesn't even have to be COVID. Whatever the virus or whatever the virus you may have, you're going to give it to the other person if you live that close. But if you give a decent distance in the outside area and you are communicating with the original virus, the transmission was low. We have had at least 1 or 2 kind of anecdotal data that has shown that even outside gathering without mask, for example, weddings in the outside, big parties in the outside, people have tested positive for the Delta variant. So we do know that the risk of outside transmission is higher for the Delta variant than the original. How much higher? I don't know the answer. Okay, so these are the things, I'm saying these things so that you can take the precautions needed. Do we know exactly how much? Have you done a control study on this? No, this is all observational data. But because the risk is high enough, I do think that we should still be sharing observational data. Okay, this is not to scare people, but it is to take it serious enough that you protect yourself, the individuals we take care of, and our families for sure. Because Delta variant also, we are detecting Delta variant in the kids as well, in the children as well. So how much? How do we? I don't know the numbers. I don't know the percentages. It's all anecdotal, observational data. But I do think that because there's so much unknown, I think all observational data we have to take seriously and do the precautions. So what can we do? Definitely at this point, masking is still, why is masking still going to be the best mitigation strategy? Because it doesn't matter how much virus I have in my body, it still has to get out. The only way it gets out is through my nose and my mouth to another outside of my body. Let's say I'm infected with COVID. Doesn't matter what variant I have, whether I have 1,000 times the viral load or less than that, it doesn't matter what the variant I have. The only way it's going to get out of me into the other person, and the virus has to get out of me to infect another person. The only way it can do that is through my words, my saliva droplets that come through my mouth, or through little nasal droplets, because we have fluid in our nose as well. We sneeze or I breathe it out, right? These are the only two holes through which it can come out. So by covering it up, doesn't matter how much viral load I have, those little droplets will stick to the clothing. If it's a cloth or a mask, a surgical mask, or an N95, doesn't matter what it is still going to filter it and hold it back. It is going to stick to that surface. So, it's not to say that none of the virus is going to get out, but a majority of the virus is going to be sticking to that barrier. So that masking, I cannot stress the importance of masking. And at this point, I think even though CDC says you don't have to mask if you're vaccinated, I think there's something will come out fairly quickly, but World Health Organization has pretty much gone out and said whether you're vaccinated or not vaccinated, everybody should mask because it helps, because there's still a lot of people who are not vaccinated around us. So it's very important that every little bit helps. And also it prevents it from crossing over and coming to you too, because there's a barrier there. The other thing is distancing. Social distancing does work, because by the time, if you give enough space between two individuals, doesn't matter how much virus another person has, the droplets will fall to the ground before it can reach another person. Okay, that's only the 6 foot is defined by how far the droplets can travel. When I speak, like for example, if I speak loud, my droplets from my mouth is going to go that much further. Singing, if you sing, it goes even further. So that is why we have the 6 foot social distancing. So the best mitigation strategies right now is masking, nose and mouth covered, not around your neck, not anywhere else, nose and mouth fully covered, and having as much a best fit you can around, and the social distancing of 6 foot, or how much of a distance you can give. I mean, if you can't do 6 foot, at least, standing, the further you are, the better your protection is going to be. All right. So that is all I know about the Delta. The other thing I want to say is the symptoms. Are the symptoms any different than the original virus? If you look at they still fall under the same symptom complex. But if you remember, for the original, we were seeing more dry cough and fever and body ache as the most common symptoms, and some people had diarrhea as well, and loss of sense and smell and taste. Those were the kind of very common symptoms we were seeing. With the Delta, it is more upper respiratory, because it attaches and able to multiply so fast. Upper respiratory. What does upper respiratory mean? Sore throat. Sore throat is very common. Headache, It's very common. It's more like a sinus headache. Um, People are having more like a runny nose. We've had individuals who were at work thinking they had an allergy, because this is that time of the year. A lot of individuals have allergies, and so they thought it was the usual allergies, and then didn't get tested. They thought it was just and then when we tested them as part of a routine surveillance, they tested positive. So it looks like more like a sinus problem, upper respiratory, like kind of runny nose, like a common cold, headache, sore throat. So if you have any of these symptoms, is more like this is more likely with the Delta. So that's the symptoms, how it's a little bit different. All right, household transmission, this is higher. As I said, the transmission rate overall is higher compared to the previous ones. How much higher? I don't know the numbers yet, but definitely higher. If you have a household member who's positive, the chance of transmission is higher than what it was for the original virus. Would it be different if it was vaccinated versus unvaccinated? Vaccinated transmission within households, even with Delta, is half of what it is for unvaccinated. But the problem is many of these households may have children who are not eligible for vaccination. So you need to take that into account as well. But transmission can occur within the households, and of course, the vaccinated is less. But really, I don't know the exact numbers. Currently, I think they say it's half less than unvaccinated. The next important thing is testing. I know there was a time when we had some, looking back, our May and June were great. April, May, June were really great months. By end of April, May, June, to the point that we were able to say, okay, we're not going to test those who are vaccinated, and we only going to test those who are unvaccinated, because that was CDC was also suggesting that, recommending that. But what we are finding now is that when we test in our state-operated facilities of our staff, we are finding that vaccinated individuals are testing positive at about 40% at least. I would say 40%. Even now, the majority is still unvaccinated, but 40% of our vaccinated staff are also testing positive. So I would say test. If you're doing testing, test across the board. You don't differentiate between vaccinated and unvaccinated. The other question is how frequently you should test, especially if you're using a Binax. I'm really high strong proponent of using Binax testing, which is the antigen testing little kit, little packets, which you'll be using. Do them at least once a week. It's very important you do at least once a week to be able to, if it's going to make any sense. So if you're doing screening testing, at least once a week, and if you have a place where it's very high risk or there's more transmission, then I would at least increase it to twice a week. The testing is able to detect the Delta variant. We haven't had any difficulty detecting the Delta variant, either through our Binax testing or through our PCR testing, which is the one that you send out to the lab. But we are seeing a much more higher viral load. That means the virus count is much higher. We are seeing that. So testing, nothing to substitute testing, symptom monitoring, testing, social distancing, back to the basics is very, very critical during this period of time. They will work, and we've gone through two real surges using these strategies, and we can get through this again by using the mitigation strategies. The other one is about, there is also something about monoclonal antibodies. So monoclonal antibodies, they are proven repeatedly, including for Delta variant, that if somebody who is, let's say, high risk, and they go through a list of individuals with high risk, for example, you are 60 years and older, or if you have an immunocompromised medical condition, if you are having other medical problems, like a combination of diabetes, hypertension, several chronic medical conditions. So they do have a list of individuals who are considered high risk. And if those individuals get their monoclonal antibody infusion, they tend to not get seriously ill. And they found that the mortality rate or the death rate was also very, very low. I mean, to the point that they think that, if given within the first week of onset of symptoms or testing positive, you are going to save that individual from going really sick to the hospital or getting on the ventilator or even mortality. So infusion, monoclonal antibody infusion is very important. It's available. The one that is approved for Delta is called Regeneron. It's the only one there used to be several, but for Delta, they found that this is Regeneron and there's one more that starts with an S. I mean, these have really complicated names. So if you do have somebody who's a high risk and they've tested positive, the best thing to do is to contact the doctor and see if they're a good candidate for a monoclonal antibody infusion, and the doctor can refer them to the infusion center. Most of these infusion centers are able to provide Regeneron infusion. It's a day procedure, 2 hours, you're done, and gives you that amount of peace of mind. Okay, that's on monoclonal antibodies. Vaccine efficacy, as I said, real life data, as I said, it's still 88% protective. Pfizer, especially for 88% protective, which is less than, if you remember, for the alpha variant, and for the original, after 2 doses, it was 95% protective, right? And we saw that. We really did see in real life 95% protection, and we did see the 92, I think 90 or 92% protection for the alpha. But the real life data for 2 vaccine for Pfizer is about 88%. This is when they've done the studies. But what Israel found is when they gave it in the community, they looked in the community and said effectiveness, because when you're doing a test, you're actually doing it in a little bit of a pseudo environment because you're withdrawing their blood and looking at whether it's neutralizing, whether that antibody is neutralizing the virus and those kind of things, which is very accurate. And we know exactly what is happening, and you can put a percentage on it, but it is not real life. So real life effectiveness data that came out of Israel, which is like they looked at the whole country, and Israel has got the highest amount of vaccination, especially with Pfizer, 2-dose Pfizer, in the entire world. I think they have more than 60 to 70% of their population vaccinated. What they found was about for testing positive. This is the word, for testing positive for COVID. They found that that 64% of the individuals did not test positive who were vaccinated, and those who are not vaccinated definitely did test positive at a higher rate, but it was still not 88% protective as the data from the labs or the lab studies showed. So the reason is, in real life, individuals have so many other factors, their own ability for your own response and your own immunity, presence of a number of chronic diseases, amount your behaviors, how much high-risk behaviors individuals are engaging in. For example, if you live in a small home and you're together and there's no real space for social distancing, of course, there's going to be more viral transmission. So those kind of data, there's a lot of that kind of real life data. So we do know that the risk vaccines protect, but how much or how little or how more, we just have to wait for more information. But really at this point, if you ask me, I am glad I have a vaccine. It's exactly the way I think through this is, what are my chances on getting in a car, in a car that does not have airbags, I do not have my seatbelt on, and I'm speeding at 85, 90 miles an hour and I get a crash. The chances of me dying is much higher versus if I sit in a car that has multiple airbags and I have a seatbelt on, and then if I drive within speed limit, I'm very good, which is the mitigation efforts will be the speed limit. But even if I go faster at 85 and don't follow the speed limit or the mitigation factors, and I get into an accident, I'm still going to survive at a much higher rate than if I did not have the seatbelt on or my car was not protected. So this is important to remember. So, personally, yes, I'm not going to go around because I'm vaccinated and engage in behaviors as if there's no virus around me. But if I am vaccinated and I also engage in reasonable mitigation strategies, I believe I'm more protected, my family's more protected, even from the Delta. Okay, this is my personal opinion, and this is how I'm thinking through this, and this is the advice I'm giving my friends. So I'm just sharing that with you. So mitigation strategies, what are the things that we're looking at specifically? Definitely, we know that our patients, our residents who have intellectual disability, a majority of them cannot mask. There's several reasons for that. It's not safe. Many of them are nonverbal. Many of them, they are not able to manage it, and that's bad. So a good number of some of our residents do mask, those who can and who are able to, but some of our residents are not able to mask. So it's so much more critical for our staff to mask. Our staff has to mask, covering nose and mouth. I see many times when I walk into facilities, I can see masks somewhere in the body, not necessarily covering the mouth and the face. So it's very critical that they have well-fitting mask and it covers the nose and the mouth. I mean, this is just like, so this is the only way the virus gets out. There's no other way. There's no other way for the virus to get out. So it's like closing your door for the virus to get out. So it's very important that we do that. The second thing is, so that is important. And the other thing is also we're still allowing enough activities, because the impact of not having activities on the mental health of these patients has been horrible too. That many of them have lost their physical ability to walk because they're not physically active. So we do encourage those activities going, but within a safer way of looking at it. And the other thing what we're avoiding is really like home, visits are important, but again, look at mitigation. So it's very, very important to look at mitigation. So I know I've gone overboard on time, Heike, and I know Station MDs also on, they have to talk. But, if you have any questions, feel free to reach out to me.
Okay, and with that, our Station MD friends, Dr. Trivedi, I believe you're still on.
Yeah, yes, and I will be as brief as possible, and then I'll turn over very quickly to Megan to give you an update. Really, I'll keep this brief. Thank you, Dr. Stanislaw. I mean, I would just reiterate everything you said. I will just add a few things that we are there, we're available. I may sound like a broken record, but there is a lot of COVID fatigue, all of us. We are all ready to get out and tired, and now this second wave is upon us, but we must remain vigilant. And I can't emphasize enough kind of what Dr. Stanislaw said, that nothing is 100%, and then there's been some unfortunate tragic cases even with people that are vaccinated, but it is our best defense. So I would encourage you, everyone has their own choice, but I myself have been vaccinated to protect myself and my family, and I think that's the way we're looking at this. Again, we are there. Anything we can do to keep individuals out of the healthcare setting to mitigate those people leaving when unnecessarily keeps them safe, but also in our community that we provide support to, it keeps the DSPs and family members safe as well, because you're putting them at risk. We are there for questions about COVID. If you have concerns, should I get tested? Who needs to be isolated? All of those things, our physicians are as up to date as we possibly can. This is a constantly moving scenario and situation, especially with Missouri and this Delta variant. So I just want to reiterate and thank Dr. Stanislaw for going through a very thorough kind of evaluation. And I love the seatbelt and airbag analogy. That's a great way of looking at this. Lastly, I will turn it over to Megan Kalishman to just give you an idea of where we are now. And I believe Megan is on. So thank you. And again, if you have any questions, please contact us directly, and we're happy to answer them.
Yeah, hi, I'm here. Good afternoon, everybody. I just wanted to, maybe could I share my screen? I was just going to kind of bring up just kind of a brief slide, but if not, I can always just talk through it as well. Okay, great. Okay. So this is just kind of just so people can kind of get an understanding of what the utilization has been. You can kind of see we kind of started last April. We've kind of ramped up during the height of when things were really tough with COVID at the end of last year. We kind of hit our peak and kind of as COVID, I think, subsided, we did lose some volume, and now we're kind of seeing that volume come up. I mean, the good news is that not all of the volume that we're seeing in this increase is COVID related. Some of it certainly is, but we're definitely seeing more utilizations from the individuals living at home and the individuals living in in different homes through the agencies as well. So, and we've been successful in really pretty much treating people in place pretty consistently, about 88 to 90% of the time, which has been great to see. So we just wanted to kind of share this information and really kind of push again for people to utilize us, no matter, really nothing is too small or too insignificant. Any kind of question or concern, we're always here to help. So please feel free to reach out. I don't know if people have any questions about any of that. I'll check the chat real quick. I didn't see any questions, so I just kind of wanted to share some of that data with everybody.
That data is extremely valuable. We appreciate you sharing that, and we appreciate everyone joining us today. If you haven't had a chance to respond in the chat and let us know the frequency for these calls, please do that before you hop off. We want to make sure we're meeting those needs and getting folks the information in the format and the timeliness that they want. So thank you all for joining us today. And after we take a look at that feedback we receive, we will send out information regarding when our next call will be. So thank you very much, everyone. Have a great day.
Take care.